Today we're talking about cardiac muscle disease. This is going to be a bigger category, and in this category we're going to talk about heart failure. So when we think about cardiac muscle disease, we're thinking about any pathology that can lead to the heart muscle not functioning as it should. So primary causes of this that we're going to see are CHF, and that can lead to pulmonary edema. So a lot of what I need you to think about while we're talking about this topic is, where is the fluid getting stuck? Okay? So when we have cardiac muscle dysfunction, the heart can't pump blood the way it's supposed to. So the ventricle isn't able to push blood out of the body. And this leads to decreased cardiac output. So the main disease process we're talking about here is congestive heart failure. This is where we're talking about, where is the blood getting stuck? Where is there congestion? If we think about the way blood flows through the body, right? So here's your little anatomy review. Blood's is going to get squeezed out of the left ventricle. It has to go through the arterial system. Blood's going to go into the kidneys and then back out of the kidneys. Blood is going to go into the venous system, and then the venous system is going to bring all the blood back to the right atrium to right ventricle, and right ventricle through the pulmonary arteries into the lungs. And we do perfusion in the lungs, and then blood goes back into the left atrium and into the left ventricle. Now, if any one of those places we get blood that kind of gets stuck, and not like a clot, but like the flow is not continuing, we talk about congestive heart failure. We're going to talk about a lot of different places in the body where we can have failure. So the most common cause of congestive heart failure is left-sided heart failure. So left-sided heart failure typically talks about left ventricle heart failure. The reason that one is dangerous is if our left ventricle is not pushing blood out, then our cardiac output slowly decreases, and we cannot sustain life if heart failure continues. So if we think about right-sided heart failure. Sorry, let's start with right-sided heart failure. This is also called cor pulmonale. So with right-sided heart failure, this could be due to right ventricular failure. So think about our anatomy here, and we think about pulmonary hypertension, or we think about a pulmonary embolus. Blood that's being pushed out of the right ventricle can't move in the way that it's supposed to. So it can't get to the lungs because the pulmonary arteries are, there's too much pressure there. Or if there's a pulmonary embolus, then there's actually a blockage, okay? A pulmonary embolus, we can think about that like a lung infarct. Blood is not moving past that vessel. And blood really has to move through that vessel to perfuse and then get back to the left side of the heart. Now, if the right ventricle has an infarct, if there's a heart attack in the right ventricle, and the right ventricle isn't squeezing blood out enough, then we might not be able to keep blood flowing. And then if there is left heart failure, if the blood in the left heart is not pushing blood out, then blood backs up into the lungs, and then it backs up into the pulmonary arteries, and then it backs up into the right heart. This is a cycle, okay? When we have right-sided heart failure, and blood's not moving out of the right side of the heart in a way that's normal, fluid will back up, okay? Fluid backs up into the liver, into the abdomen, and into the lower extremities. So you see the picture here. This is actually what a person with right-sided heart failure really looks like a lot. They can have lower extremity edema. They're going to have weight gain, and a lot of times a lot of fluid gain. They may not eat much. One of the signs that is very indicative of heart failure is distended jugular veins. Jugular venous distension. So if the patient is laying on their side, they kind of turn their head to the side, you can, to the left, you can actually see the right jugular vein. It's kind of bulging out in the neck, and sometimes it's even a little pulsatile. Okay, veins aren't pulsatile, right? That's not good. That's because there's so much fluid backed up into the right jugular vein. When we think about left-sided heart failure, this is almost always due to left ventricular impairment. So most of the time it's due to heart attack on the left side of the heart. Now, the other reason you could have left ventricular or left-sided heart failure would be if the afterload. Remember, afterload is the pressure that the left ventricle is pushing against to try to move the blood. If you have increased afterload, and that left heart muscle has to work harder and harder and harder, eventually it will hypertrophy. The muscle will actually get bigger and bulkier. When you have that left ventricular hypertrophy, it decreases the stroke volume. It decreases the end-diastolic volume, and it decreases the ejection fraction. You also have a non-compliant muscle there. It's very hard to stretch, so we lose Starling's mechanism to help increase that cardiac output. When the left side of the heart is not pushing blood out quickly enough, fluid backs up into the lungs, and then we go through that whole cycle again with right heart failure. It can back up into the liver, the abdomen, and lower extremities. So left-sided heart failure can cause right-sided heart failure. Right-sided heart failure can cause left-sided heart failure. So if we think about why does right-sided heart failure cause left-sided heart failure? If you have right-sided heart failure, let's go back one, and you have fluid that's backing up into the lower extremities, that's into the venous system, and then as our arterial system tries to push blood, we have this hydrostatic column of fluid. We've got this increased pressure that's coming all the way back and is acting like increased afterload. When we have increased afterload, we get left-sided heart failure. So right-sided will cause left-sided, and left-sided will cause right-sided. It is one system, in fact. Okay. When we have left-sided heart failure, a lot of times we will have pulmonary symptoms, coughing, crackles, tachypnea, and this is because there's so much fluid there, we're not getting good perfusion. Even if we have good ventilation, we're not getting good perfusion. So remember, with congestive heart failure, you're going to end up with difficulties with perfusion and ventilation. Okay. A lot of times these patients too will have more difficulty breathing laying down, so that's orthopnea, and they're going to have, because our left ventricle isn't working as well, our cardiac output is going to decrease, and that is going to cause a lot of exertional dyspnea, so a lot of dyspnea during activity. So let's look at a picture of this, okay? So we've talked about ejection fraction, and here's a nice little picture here that demonstrates what's going on. You notice that during diastole, those ventricles are relaxing and we get a lot of blood. And then as it squeezes, we get a lot of the blood out. When we look at this picture on the right and we look at heart failure, on the left ventricle, we have this really thickened myocardium. Okay, that's called ventricular hypertrophy. When that happens, that stroke volume is decreased. So we don't get that relaxation quite as much. So our stroke volume we're putting out is a lot less. We've talked about right and left heart failure. The next thing I want to do is talk about low output and high output heart failure. So you can have heart failure with a preserved ejection fraction. You can also have heart failure with a reduced ejection fraction. So when we talk about low output heart failure, This is usually what we see with left-sided heart failure, and we end up with low cardiac output at rest and with activity. So the heart can't pump out the amount of blood that is needed to support circulation. So let's think about that term, support circulation. The heart has to push blood out with enough force, with enough pressure, enough systolic pressure to keep moving the blood around. The heart is the pump for the whole system. So if we have a low cardiac output, then we're not getting the amount of pressure that we need to support the system. Now, high output heart failure is less due to cardiac muscle dysfunction and more due to just volume overload in the whole system, especially in the renal, if the renal system can't pull off fluid. The heart and the lungs have this interesting relationship, and we're going to talk about it a little bit later. But the heart is pushing blood out that feeds the lungs, heart push bloods out to feed the kidneys. The kidneys measure how much fluid there is, and sometimes they'll pull fluid off. Sometimes if there's not enough fluid, they won't pull anything off. And that fluid goes back to the heart. So if the kidneys aren't pulling fluid off, then we end up with a higher volume of blood. So during renal insufficiency, or acute kidney injury, or during pregnancy, we can have this high output heart failure. Important to remember that even though it's called high output heart failure, the cardiac output is still not normal. It's just a more normal, a closer to normal heart failure than the low output is. All right, here's another way to describe heart failure. We can talk about systolic heart failure, and we can talk about diastolic heart failure. So with systolic heart failure, the ventricles cannot contract. Okay, they can't squeeze the blood, so we have that lower cardiac output. Systolic heart failure happens a lot of times when we have a myocardial infarction, right? So anytime that muscle can't squeeze well. Now, diastolic heart failure is when the heart cannot accept blood from the atria. So the ventricles can't accept the blood. So if you have that non-compliant tissue, so like a scar from a heart attack, or you have that left ventricular hypertrophy, that blood is not accepted into the ventricles. And if we don't fill the ventricles, then we have a lower end diastolic volume. We're going to end up with a lower stroke volume and therefore a lower cardiac output. The other time that you might have a systolic heart failure is if you have a cardiomyopathy. So kind of like a floppy ventricle. So chronic heart failure can be due to cardiomyopathy. It could be due to congenital abnormalities. It could be due to chronic renal insufficiency, and it could be due to aging. So if we think about that cardiomyopathy, that muscle is not working. Okay, the heart muscle is not squeezing for some reason. We talked a little bit about that renal insufficiency. So the kidneys stop pulling blood off, so you have an increased blood volume that the heart can't handle very well. And then we've got aging. Now, as we age, our ventricles tend to not squeeze quite as hard. Okay, so our cardiac output kind of goes down a little bit with age. And you know this tacitly because blood pressure tends to go down with age. The other thing that happens is as we age, we lose some of that ability for our heart muscle to stretch. So we don't have the ability to use the Starling mechanism quite as well. And that can lower our cardiac output. Now, those are chronic disease. These are people that have it all the time. When we think about acute heart failure, so an acute exacerbation of heart failure, we think about people who have acute hypertension, right? So the afterload is increased, so the left ventricle is not able to push blood out as well. We talk about coronary artery disease, so acute MI. This might be an NSTEMI, this might be a short-term thing, or this could be immediately after an MI. You know, after an MI, we end up having cardiomyopathy, so it's chronic heart failure, but acutely, a patient might show signs and symptoms of heart failure during a heart attack. Some cardiac arrhythmias are going to change the cardiac output, so that can cause heart failure, acute renal insufficiency, or heart valve problems. So when we have an abnormality of the heart valve, if the heart valve, let's say the aortic valve, doesn't close all the way, it's really hard to build up the pressure or to build up the volume in the ventricles needed to squeeze out. Or if we have so that would be regurgitation. If we have an aortic stenosis, aortic valve stenosis, where it doesn't open all the way, as the ventricle is trying to push blood out, not as much blood gets squeezed out. And that increased pressure that the ventricles have to squeeze against can cause left ventricular hypertrophy. Now, on the other side of the heart, we can talk about pulmonary embolus. So the right ventricle can't move blood through the lungs. Pericardial effusion. So if the pericardium is full of fluid, then the ventricles cannot expand during diastole, which is going to decrease our cardiac output and present as a congestive heart failure. And then spinal cord injury. With a spinal cord injury, we end up having lots of dependent edema. And dependent edema can increase the afterload. It can also have effects on the preload. Okay, so I have decreased preload with upright positions, and you're going to have increased preload when you are supine. So after a spinal cord injury, we can expect to have some acute heart failure type changes. This is the end of the first part of congestive heart failure.